First of all, I apply a tourniquet like so. You know the tourniquet is too tight if the patient complains that it's too painful, or if you can't feel a radial pulse. Other things are to lower the hand below the patient. This increases the hydrostatic pressure gradient and makes the veins stand up more than they would if the patient's hand was above their head. Simple things are to get the patient to open and close their hand to make a fist, and this increases the amount of blood flow to that particular region. Other simple measures include tapping the hand gently or rubbing the vein. What this does is it increases vasodilatory mediators, which make the vein dilate again. Now, hospitals are almost universally very cold places, and cold patients will vasoconstrict, whereas warm patients will vasodilate. So another very important tip is to make sure your patient is comfortable and warm, and this will help the vein stand out. Some patients have very, very difficult intravenous access, and it's important in these patients to ask them, where is your best vein? And so they will tell you exactly where the best vein to access is. So first of all, wash your hands or cleanse them with an alcoholic solution like so. I first apply the tourniquet and then set up my equipment, as this gives time for the veins to enlarge and to dilate. I prepare by putting a glue underneath the arm, and this avoids a lot of cleaning up later if you do have a bit of an accident. I bring the sharps container, so it's right nearby and very easily accessible. I then open a dressing pack and assemble all my equipment. So I then open my dressing pack and assemble the rest of my equipment. So in the dressing pack, I mean, this is pretty comprehensive, but all you really need is a container to put chlorhexidine in and some gauze. I fill with chlorhexidine and alcohol solution, and this has been shown to be better than alcohol itself to reduce infection rates with peripheral IV cannulation, and put the gauze inside as well. Yeah. Next thing is the rest of our equipment involves a tegaderm, an IV bung, which seals off the cannula at the end, which I'll show you in a second. I want 10 mils of normal saline, which I drop in a 10 ml syringe. And I usually put this and place it on the end of the cannula, just so I have it ready and loaded. And I flush the cannula, the IV bung, with that. I then get an appropriately sized cannula, and I have this ready as well. So essentially I've got my tub with chlorhexidine and alcohol solution, I've got my cannula ready, I've got my bung to place on the end, and a tegaderm. The rest of the other equipment here is really unnecessary for this particular step. The next step is to don a pair of gloves. It's absolutely important that you put gloves on before any invasive procedure, as over the lifetime of your practice as a medical practitioner, it may actually save your life. I then identify the area that I'm going to cannulate. I tap and rub the vein as we demonstrated previously, and I apply the chlorhexidine with alcohol solution to ensure that the area is nicely cleaned. I then stabilize the skin like so, and I'll outline exactly how to do it in further extra tips that we'll go through. I then pick up the cannula with my thumb and middle finger, and now I'm ready to cannulate. I need to then identify the best vein, and when you're starting out, the bigger the vein is and the straighter it is, the easier it will be to cannulate. I also like to identify any bifurcating veins. In this patient there isn't one, but if it bifurcates, it means that if you go at the point of bifurcation, the vein is less likely to roll away from your cannula. I then taut the skin, tense the skin. I line up my cannula along the axis of the vein, and note the axis there. I do not go either side, as again, that will increase the risk of rupturing one of the walls. I approach at a very low angle. It's about 5 to 10 degrees at the very most. If I was to go at a much steeper angle, the risk of me puncturing the other side of the vein is much greater. So I approach at a low angle, I tense the skin, and I insert my cannula like so. I don't rush this point once I'm through the skin. I advance the cannula very, very slowly, again along the axis of the vein, until I see a flashback. up in the chamber of the cannula. When I see that, I level the needle out even further and advance up to 1 centimeter. At which point, I now can stop. I know that my needle and my cannula is in the vein. I use then my pointer finger to advance the cannula, the plastic part of my cannula, across. I can now pause at this point because I know everything is there and in. I then take my tourniquet off and put pressure on the distal part of my cannula to avoid any blood rushing back. I then very slowly and controlled, I take the needle out and put it directly in my sharps container. I take the IV bung and I screw it on to this cannula, stabilizing it again with my other hand. To check that the cannula is in the vein, I simply flush with my normal saline solution. I twist off my syringe of normal saline and apply a tegaderm to ensure that the cannula stays in its proper place. I'll now demonstrate some important principles when anchoring the skin. So firstly, I use the thumb of my non-dominant hand to stretch the skin. The important principle here is to stop the skin moving as my needle enters the skin and makes this step much smoother and less painful. It's very important to make sure my thumb is out of the way of the needle. If my thumb was here, on top of the knuckle ridge, I wouldn't be able to gain the right low angle because my thumb would be in the way. For that reason, I have my thumb below the knuckle edge, which allows me to lower the angle of this needle as much as is required. I'll now demonstrate the correct way to hold the cannula. So first of all, place the cannula with the bevel facing up on your dressing pack. Pick the cannula up between your thumb and middle finger and always have the cannula below your hand. If the cannula is above your hand, it means that you won't be able to get the right angle necessary to advance, the right low angle that's necessary. So having the cannula below is always quite vital for this procedure. Your pointer finger should always be out of the way, so it's not covering the hub. This way you can observe a flashback of blood in the chamber as soon as that occurs. And having this pointer finger free also allows you to advance the cannula without using your other hand to do so. This makes the whole system much smoother and efficient as you put the cannula inside. Finally, I use my fifth finger as a very important part of stabilizing my hand and avoiding tremor. So say I have my patient use the little finger to stabilize it against any firm structure, allowing me to advance smoothly without a tremor. I'm now going to demonstrate some important cannula features. First of all, the cannula has a very, very sharp tip, which means it's easy to get access into the vein, like so, but unfortunately also means it's very easy to go through the other side and blow your vein, like so. The other aspect of this is that the cannula has a relatively non-cutting upper bevel edge, so it's quite smooth. It means that when you go into the vein, if you were to flatten out, there's very little chance of you, even if you tried very hard, to cut the upper surface of the vein. And that's why I highly recommend flattening out the cannula as much as possible before advancing, because there'll be much less likelihood of you going through the other side. Even if you were to angle, say, 10 degrees or 5 degrees in a very small vein, there's a good chance that you may go through the other side of the vein. Before you cannulate, it's important to identify the best vein. And when you're starting out, the big straight veins are probably the easiest ones, like this one here. It means that it's less likely that you'll go through one of the side walls or the deep wall. It's also a good idea when you're starting out to look at bifurcations, and this is a good example. The vein runs this way and then bifurcates into two pathways there. If you go in the middle of that, it's less likely that the vein will roll to one side or the other. So for these purposes, I'm going to approach a the vein just in the middle of the dorsum of his hand here. So first of all, I stretch the skin 5 and a maximum of 10 degrees. And this means that I won't have a sharp angle that is more likely to puncture the other side of the vein. I identify a point of needle insertion and I line up my cannula along the line of the vein and not to one side or the other, which means I might go through the side wall. I stretch the skin firmly as I first enter with my cannula. I go as slowly as is required, always looking at the blood filling chamber, to see if I get a flashback. And see, you can see the flashback and the blood filling up. At this point I take all the time I need and level out even further as I advance the cannula up to 1 centimeter. At this point, I then use my pointer finger to advance the cannula into the vein. I then take the tourniquet off and using my non-dominant hand, put my thumb over the distal end of the cannula to stop this bleeding. I then take my sharp and put it directly in the sharps container. Note that I've got all the time in the world, I don't need to rush, there's not going to be any blood flowing back, and my cannula is in the vein, it's safe, and now I need to secure it. I take my syringe with the IV bung and place it directly on the end of it. I then flush the cannula with normal saline to ensure that it is in the vein. I then secure a tegaderm or an opsite or some sort of dressing over the cannula to ensure that it stays in the right position. And there you have it.